So this particular breakout session is Bytes for Better Health, transforming healthcare through digital innovation. In a world where technology advances at an unprecedented pace, the healthcare industry stands on the brink of a transformative era. This session will explore how digital innovation is reimagining the way we deliver healthcare and how the push towards interoperable systems is critical for enhancing patient care and improving efficiency across the system. It is my delight to introduce the chair of the panel, Peter Wood. Peter is the General Manager of St Stephen's Hospital in Hervey Bay, which was Australia's first fully digital hospital. Since its opening, St Stephen's has had a new standard in healthcare through innovative use of technology to enhance efficiency, empower healthcare professionals and improve patient experience. It is also my pleasure to introduce the other members of the panel, Professor Steve Robson, who is the President of the Australian Medical Association, Julia Conway, Director of Hospital Policy and Projects at the Independent Health and Aged Care Pricing Authority, IHACPA, and Michael Hosking, Deputy National Coordinator of the Sparked Fire Accelerator at CSIRO. Please welcome the panel.
I'm like the least digital person possible. I still have paper notes and things like that. But I understand completely why we need to be digital, and I'm frankly in awe of anybody who is digitally competent. And when I look around at the landscape around us, I see now that it's possible to have a consultation with a general practitioner, and a sort of AI scribe will record and listen to the conversation and the consultation and will capture with increasing accuracy the substance of what goes on. And that's something that's absolutely unheard of. The history of digital innovation in medicine has just often been making people's lives harder. And I think that we see this in data from the US. So the more digital things are, the more people end up having to enter more and more data that has no particular relevance to patient care and the patient in front of you. Anyway, I am an old-fashioned obstetrician gynaecologist based in Canberra. I'm the Federal President of the Australian Medical Association, but I don't want my incompetence to reflect on the organisation as a whole, which really is a very modern and digital organisation. So we've actually been reflecting the views of our members for close to 20 years, and we put out our first statement almost 20 years ago, when we were very, very concerned about the profusion of practice software that was being used, and there were all sorts of different software platforms available at the time. Some of them were clunky, some of them were old, but they were very, very popular, and we could see the potential of these, and we wanted to make sure that as we move forward that we had some guardrails around these. And it was clear to us at the time as an organisation that digital health was going to be really a critical enabler moved forward in medical practice in the country. And we wanted to make sure that it was used as a tool to improve continuity of care and patient care. It just wasn't another burden that people had to battle with, another thing that was constantly buggering up your work and things like that. Over the last 17 years, we've been very, very keen to make sure that quality and safety are the hallmarks and the guardrails around all digital platforms that we have. And we've certainly been leading the charge for development of standards-based functionality in medical software. And we've been pleading with software developers to implement standards and make sure that we have a system of quality assessment. Doctors around the country, apart from me, are very keen to innovate digitally, to use all of these technologies to improve patient care. So we need to make sure that it's actually about patient care, and that's what we're aiming to do, and not just about whiz-bang stuff. And as we move into AI and we get into things like decision support, where the data that you put about the patient in front of you will help inform the way you treat patients, and we grapple with issues of indemnity around whose responsibility is if you follow the advice of the AI that's part of your practice software, then it's critically important that we have digital software that's interactive and works across the system. And the key things really are interoperability and making sure we just don't have a series of siloed digital systems that don't talk to each other and in fact often impede care because you end up flicking from one system to another. And we certainly have seen this across public hospitals The public hospital I work, you had to log on to 5 different systems, whether you wanted to get imaging results or you wanted to get pathology results or you wanted to see old correspondence. And they had this great digital system where you wrote on paper and it was scanned in and you could look at the PDFs of what you'd written on paper. So it was sort of paperless once you'd written it down. So all of these systems have been things that have infested digital healthcare and just made everything worse and harder for everybody. So the things that we really, really want are stability and usability, a user experience that really puts the patient at the forefront in patient care. And we want to make sure that we don't break the bank trying to provide a digital system that still isn't quite as good as we want it to be. So I apologise for my low level of digital literacy here, but I'm very happy to kick things off, and I'm sure I'll give you some very interesting answers to questions down the track. So thank you.
Good afternoon. My name is Julia Conway. I'm the Director of Hospital Policy and Projects at the Independent Health and Aged Care Pricing Authority, or AHACPA. So a bit about AHACPA. We're an independent agency originally established under the National Health Reform Act and National Health Reform Agreement to determine the national efficient price and national efficient costs that inform the Commonwealth funding contribution to Australian public hospital services. And we also develop and refine all of the data collections, classifications and costing systems that underpin those funding arrangements. In 2022, our role expanded to commence providing advice to the Minister for Health and Aged Care on pricing for aged care services. As part of delivering these functions, AHACPA seeks to ensure that pricing systems support good patient care and outcomes, as well as improving efficiency across the system over time. Together, these two aims feed into the delivery of more value-based healthcare, where there is a focus on both improving outcomes while ensuring that the costs involved with delivering those outcomes remain proportional. And so reflecting today, I think there's a number of ways that advances in digital innovation are contributing to this aim. So broadly, we know that optimising information transfer within hospital systems through the use of effective medical records and patient administration systems can support improved clinical decision-making, efficiency, quality and safety, including through factors such as reducing duplication of testing, risk factor identification, medication management and transfers of care. A particular area that we've been looking into recently at AHACPA is emerging virtual care models, such as models that support acute virtual support to other hospitals, such as telestroke and virtual emergency departments, as well as remote support to high dependency units, so to provide continuous monitoring, for example. And there are also a range of remote patient monitoring models emerging, supporting continuous or intermittent information feeds back into clinical systems to monitor trends and identify potential clinical deterioration, thereby enabling patients to be cared for in lower acuity settings than otherwise possible, including home or aged care settings. And so these systems can support more effective transitions between hospitals and other types of care, including the primary and specialist care or aged care services. And effective systems, particularly where these will become increasingly interoperable and support more seamless transfer, will support more comprehensive and timely care for patients at these boundaries and crossing these boundaries, and thereby hopefully avoiding readmissions and representations to emergency departments. Furthermore, the increasingly rich data that can be and is being generated by these systems can also support innovation in care over time, such as through better understanding patient journeys, risk factors, and outcomes over a longer period. This can support research, service redesign, and also support refinements to the systems that AHACPA looks at more closely, so that includes patient classification, risk adjustment, and funding models. So, for example, potential development of more bundled funding models will need to consider the components of care that are being delivered across a period of time, how these link together, and also how these link and overlap across different health services and systems and sectors even. And on the provider side, working to optimise care within a bundled payment framework will rely on being able to effectively link together these components in a cost-efficient way. And so information transfer in an efficient and cost-effective way will be critical to that. And then finally, just linking back to my earlier comment around value-based healthcare, I think it's really important in both bundled payment context, but also other funding models, that we're designing and implementing digital health systems that at their core are focused on actually improving patient outcomes and improving those with proportional investment into the systems that are supporting those. So I might leave it there. I'm looking forward to the discussion.
Hi everyone, my name is Michael Hosking. I'm the Deputy Lead for the Sparked program with the Australian eHealth Research Centre with the CSIRO. So I have a clinical background actually. I'm an occupational therapist by training and somehow managed into the digital space, but I think I was more or less frustrated with shuffling paper and dealing with faxes and crazy things like that. But I've had a career in digital health for the last 10 years, working for software companies, implementing systems, influencing, I guess, international policy in New Zealand. But now I'm with the CSIRO. So I'll give you a bit of a brief overview of the CSIRO and our work, and then also there's a nice segue from the previous speakers in terms of interoperability, which is fantastic. So in terms of, I guess, the eHealth Research Centre, we're the first and largest eHealth research hub that was started in 2003. And we've now grown to 150 scientists and, I guess, students and engineers across the country. And we provide an evidence base for, I guess, digital transformation in the healthcare space. And we work in partnership with many organisations, both public, private and international standards bodies as well. In terms of the trends that we're seeing, interoperability is actually a huge one that we work in, and we work with the Australian Digital Health Agency and the Department of Health in terms of their digital health blueprint and the interoperability roadmap that's out at the moment. And we also have strong cloud infrastructure to enable those interoperable mechanisms to ensure that data flows through the system effectively. And then we've got, I guess, apps and personalisation to ensure that the interface of how people interact with that data is available, and also ensuring that, I guess, once we've got strong cloud and interoperable systems and quality data, that provides a really good base for a strong data analytics, and then also the exciting capabilities around artificial intelligence and machine learning. And to be able to do that, we need quality data in the first place. So more or less you got crap data going in, you're going to get crap data coming out. And I think one of the really exciting things is in terms of, I guess, being able to have consumers and patients in control of their medical record, like in the US, where they've got people using their iPhones to transfer and access their health record through the iOS system. And interoperability, this comes into the program that I'm working on. So fundamentally, it's a funded program by the Department of Health, and they've said, we want standards, and we want interoperable standards that all systems should be used by the ecosystem. And who better to do that than the community itself, in terms of government agencies, technology partners, provider organisations, peak bodies, health practitioners, consumers and domain experts, to inform what that standard looks like. And we're doing that through a standard called FHIR, stands for Fast Healthcare Interoperability Resources. It's a bit of a mouthful, but it came actually out of an Australian founder through HL7 Australia, created the standard. And it's the standard to ensure that health information is shared in a proper and standardised format. And to me, standards are only as strong as their community, and we've got a really strong base in terms of this 2-year program, and we're 1 year into it, and we've had over 800 individuals and organisations join, and you can see here there's some strong membership, and we've got Catholic Health Australia here, so fantastic, thank you very much. And any organisation who believes and wants to be involved in the interoperability space, informing what we do, we have availability for you to join and put yourselves up there by the end of 30th of August. So what are we doing? We're defining with clinical leads and clinical, informed and interested people to define what data do you want and what workflows do you want to support so that data can flow seamlessly through the system and can be captured once and used multiple times, because that's what we want. We want quality data captured at the source of truth and used aggregated up to inform decision support and also policy levers in terms of, informing policy and the approach in terms of how we invest in our services. And then that's where the clinical design group, which meets on a regular basis to inform what those things look like. And you don't have to be a technical whiz. Stephen, we'd love you to have to join, or anyone from your organisation. But to inform what those things look like. And then the technical design group, are the implementers, the software providers who define, based on those clinical requirements that have been defined by the clinical people and the consumers themselves, how can we translate that into a technical specification that actually can be implemented into our systems? So the way you can participate, we've got those clinical design groups, which I mentioned, we've got technical design groups, which I've also mentioned, and we've got regular webinars that we hold and host to support people who are interested. We've got open source development in the sense that everything that we do is publicly available. So we've got a website that everybody can see our work, see why we've made decisions, who's been involved, all of our notes and documentation's all kept up to date. And we have connectathons, which sounds a bit weird, but it's more or less where technical people come in and connect their systems to see if in a sandpit environment they can share data through their corresponding systems. And then we pilot the standards to make sure that they're fit for purpose and they actually solve the problem that's been defined. And then we go through a balloting phase in terms of making sure that we vote for what the standard looks like. As you can see here, in a year, we've a lot of good stats here in terms of we've got over 600 people in the clinical design group and over 500 and 400 groups respectively in terms of the technical design groups. And we've got a strong social media presence, so follow us and see what we're up to. And if you have any questions about what's involved in terms of becoming a founding member, please let me know. And we're always keen to have more people involved. And here's a way you can register to be involved or follow us on social media. And I look forward to the conversation. I think this is fantastic to see this calibre of people talking about interoperability. And thank you very much.
So I'm Peter Wood, General Manager for St Stephen's. I've been in this role for about 18 months now. And before that, 6 years in the public sector in Australia, 11 years in New Zealand, and then 17 years in the UK system, and a nurse background with a military medic history as well. And I'm on Stephen's team because I'm not a digital advocate, but what I am an advocate for is enhancing the level of care that the nurses, the staff can provide in the hospital. So from a St Stephen's point of view, does a digital system help to provide improved outcomes for the patients? I'm on the fence, to be honest, because if you're not careful, you can put a digital system in place and people get distracted with the digital system that you've got in place instead of talking to the patient face to face. I learnt many years ago, ex-military, big and strong, went and worked in a friend's garage, and he used to say, "Can you just take that cylinder head off and put it back on and tell me exactly what to do?" What he didn't used to say is, "Don't snap the bolts in the cylinder head because you could probably damage the engine and it's all broken." The second time I did it, I learned a lesson from him. I was panicking. I said, "That's it. £2,000 lost, the engine's gone, what will I do?" He said, "Pete, never forget there's always a tool for the problem. You may not know what that tool or solution is, but always remember there's a tool or tool or solution for that problem." So I think of digital health, digital systems, digital health in exactly the same way. If it's a tool to support patient care, to support the staff, and also to improve patient outcomes, that's what we need to put in place. I find that staff are really enthusiastic in St Stephen's Hospital. And I like analogies because I don't think in a deep level at different times. So my analogy is that you can ask the staff to do many things in the hospital and they will do everything that they can do to support patient care, because that's what it's about, improving patient care. But wouldn't it be great if you gave them a tool that helped them to do the job? If you said to me, can you change that wheel on that car? I'll change that wheel on that car. I'm enthusiastic, I'll chew the wheel nuts off, I'll try and lift the car up. But if you give me the jack and you give me the wheel brace, I'll be able to do it a lot quicker and a lot easier. So I constantly think of those types of things. St. Stephen's first fully integrated digital hospital was the stamp 10 years ago. And then 10 years later, we've lost some of the functionalities of the digital system that we had in place 10 years ago. And if you're not careful, if you don't upgrade the system, the technology changes. I buy a phone 12 months ago. I want a new phone because it's got new technology and new systems. And the challenge is that comes at a price, and especially at the current economic challenges that we're all facing at the moment. The cost of a digital system is additional cost to a hospital that doesn't have that system, and unless you can translate it into improved clinical outcomes, efficiencies, increased activity through the hospital. So examples of what we've lost in the St. Stephen's Hospital, we used to be able to track every single piece of equipment. And I think, we have the Apple AirTags that you can track your daughter to see what she's up to, if that's what you want to do. But we don't have that system in the hospital anymore. We used to be able to track every single piece of kit. They have Vocera in the hospital as well. Vocera is the communication device, and you can track through the hubs, through the network hubs, exactly where the member of staff is. They're in the car park having a cigarette maybe, or something like that. So we still have that functionality, but it's not been upgraded, and those things are coming to the end of the life because we've got to prioritise the dollars that we've got into improving patient care, not always investing on an ongoing basis in the technology that we've got in the hospital. Another example of a technology that we've put is the Vocera. Does anybody know what they are? Just a device you can talk to, but the problem with that is that you've got to talk outwards and you're speaking to somebody here. So I can be looking at you and talking to Terry that's on here, and the communication link's broken when you're doing that because we're used to engaging face-to-face or through the phones and those types of things. So we've got to be careful what we wish for when we put technology into the system. So that's just St. Stephen's, relatively small, 5 operating theatres, 96 beds, fully digital. We don't use paper. We don't use paper at all. And that's great until you need to interface with the public sector, because the public sector send patients and they want to send paper. And then once we've seen the patients in the in the private sector, if we've got a public-private contract, guess what they want? They want printed pieces of paper to go back into the public system. And for one episode of care, a patient for one day could have 28 pages of pieces of paper that we need to scan and put through the system. So that portability conversation is a really important conversation to have. Digital landscape, electronic medical record. In different countries, there's different levels of different integration, and I've seen Concerto in New Zealand that work really well from a rural perspective. I've seen metro hospitals have good integrated systems, and the principle is the flow of information, not the blockage of information, because the private GP practice have got a different system compared to the public system, compared to a private hospital system as well. We have centralised nurse call system, patient entertainment systems. And what I found being in the short time in St. Stephen's Hospital is that because of the journey has been 10 years in evolution, and we've lost some functionality either because we've upgraded one system here and that's affected this system, or the pieces of equipment have become obsolete and we haven't renewed them, we've lost that functionality. But also, if you're not careful, you also stop seeing what you should be seeing. In other words, when I look through the hospital, we may have a digital system that allows us to display electronic dates of discharge, patient communication, interface with relatives and patients that can be fully digitalised. But because we haven't upgraded that system, we're not using that system, and the staff have stopped seeing those opportunities within the digital hospital. So the journey that we're trying to go on now is to create that innovation and that incentive to get people to start seeing things that they've stopped seeing. I'll just give you a simple example. I was going to pretend to trip up, but I might hurt my knee. Because if you're not careful, you know, when you're tripping over something, people start stepping over it. So they're treating the symptom, not the cause. And in one example, in the hospital that I'm at, they used to have a they used to provide food, catering food for the hospital, for visitors, for GP forums. And they had what do you call them? Bain-Marie with a little flame to keep things warm. But because the Bain-Marie flame could trigger the smoke alarms, they had to turn off the smoke alarms for a fixed period of time until you finished all the catering and moved them away and turned the smoke alarms back on again. So a simple solution for me is use an electronic Bain-Marie so you don't have to do all that switching off and putting back on again. And again, that was a simple example that if you're not careful, you'll lose sight of the innovative opportunities that you could create in a hospital setting. Phone systems, patient medical devices, Mako robots, that's just one example of the robots that we use, but there's a lot more technology coming into place. Virtual hospital is an interesting journey that we're experiencing at the moment. The clinicians want something greater than what we're able to deliver, but we could deliver that at significant expense, but that expense, that cost, the dollars aren't available at this moment in time because we've got to reprioritize into other areas. And that causes a bit of a conflict between the clinician that wants to drive an innovative practice that we're left behind a little bit. I'm not being too bad on St. Stephen's, I hope. It's a positive thing, but I'm just talking through some of the experiences that I found. Many years ago, I used to think in the UK, I used to go to my local supermarket and buy my lunch. And when I bought my lunch, I went to the checkout, and there was 2 beeps at the checkout. And I thought, what are the 2 beeps for? And the 2 beeps were selling the item to me, but scanning it to restock it, to replenish the stock in the background. And I asked the guy in the store, what's your stock level? He said £30,000 at the time. I went back into the hospital, and I was managing operating theatres. We didn't have that system, and we had something like £12 million worth of stock on the hospital. And we didn't have that simple system that was in place in a local supermarket. So I think we've got to be innovative and responsive to the current technology changes as well. Another example, when I go to the gymnasium, I see a beautiful screen, tells me where to be, what to do, and how to do it. But I don't have that same functionality of a simple app for St. Stephen's Digital Hospital at the moment. So we need to continually invest in innovation to allow us to have these devices. I won't talk through those. We've got to maintain the quality of services instead of cutting corners, utilising the workstations on wheels. You've got to maintain a high level of output. And if you're not careful, as a consequence of having an electronic system, is that I'm a nurse and I'm doing my checks. Check this, check this, check this, and it's become a checklist instead of putting the system to one side, speaking with the patient, going through all the assessments you need to do, then going back to your system, and then confirming the interactions that you've had with the patient. So we've got to make sure that we're maintaining a patient-centred approach instead of using the system to deliver the care. We've still got to deliver the care through the workforce that we've got. And that was it. So I think now it's open to some questions.
Sorry, just to reiterate the question, was it how useful or how soon will AI be? Right. So I think AIs are available at the moment in terms of some, I guess in primary care, we've got examples of AI scribes, which I've been hearing, even my father, he's a GP and he uses it on a regular basis. And he's found that it's very useful and helps interact with patients a little bit more seamlessly. In terms of, I guess, the quality of that data, that's the important part. We want to make sure that, I guess, also the integrity of the data, making sure that the clinicians have the, I guess, expertise and oversight over that rather than necessarily just having the AI capture the notes and then shoot it off. There needs to be a process ensuring that that is, I guess, reviewed appropriately, but in terms of it being useful, I think it's useful now, but I think there's, through interoperability, we need to make sure that the data that's being captured and used in terms of informing the AI is actually of a high quality, because otherwise, if we're relying on AI right now and we're relying on the data quality that we have right now, then that's a cause for concern. But I think it exists now, but I think there's a lot of opportunity if we get data quality right.
Sue Williams from Cabrini. My husband is a doctor that works in the public hospital system. Two things he talks about. The first thing is he says his ward rounds have increased by an hour and a half because of the amount of time it takes to work on the computer. The other thing that concerns him is that his residents and registrars don't look at the patient, they look at the computer. So how do you resolve that problem? And my second question is in relation to the electronic medical records. The key ones people are using are Cerner and Epic, and those databases are 20 or 30 years old. How far away do you think the next generation of electronic medical records are?
I'm with your husband. I find it a total, complete and utter nightmare. So we've had a thing called Epic for 2 years at the public hospital I work at, and I found it was such a disaster. The politicians were saying, oh, what a wonderful thing this is, but in reality for someone like me, and I've had several senior colleagues retire because they couldn't cope with it. Now that's catastrophic in a place of workforce shortage when the most senior people are the ones who are actually leaving. So the way I run an outpatient clinic these days is I do what I suspect your husband likes, which is I sit down, talk to the patient, examine them, talk it through. My trainee does all of the digital stuff off to the side and prints out prescriptions and things like that. So we do not have that division of someone saying, what's this? Or worst of all, asking questions while looking at a computer screen. So I agree with everything you've said, and that's why I'm so cynical. I think it's such a catastrophe. It's a great ribbon-cutting stuff for politicians, but for some of the most senior people in the hospital, and I'll die soon, so that problem solved. But, at the end of the day, at the moment, this transition period, it's awful. It's really awful.
Yeah, I think that kind of reflects what I was trying to get at earlier, is that, it is great to have better digital systems and be getting this information in, but it needs to be in a balanced way. You can't be sacrificing, patient outcomes and actually having workforce and things like that. So I don't know what the solution is, but I think it's, how can we transition it in better? And maybe, advances over time will help with that, interoperability and things like that. But yeah, it's not an easy answer for sure.
Mike, what do you reckon?
I think it is a challenge, and I think it is, a really frustrating moment in terms of the systems not talking to each other. The exciting thing that I see is through the work that we're doing with Sparked is, we've got Epic and Cerner involved and leading the conversation in terms of what data should be shared through the system and what is the minimum amount of clinical information that should be shared and standardised through the system. And another exciting thing to me is that, all the stars are aligning. So this 2-year program that I'm working in has been funded by the Department of Health, and we're working in partnership with the Australian Digital Health Agency, CSIRO, and HL7 Australia, the standards body. And the Department of Health have actually signalled that they plan on mandating these standards. So the incentive for industry partners to be involved is quite high, so that when the mandates come, I don't know when or how that will look, but I think I'm quite optimistic in terms of there's going to be a minimum expectation of sharing data in a structured and standardised way, and good quality data as well.
And that's a good example, because the system shouldn't drive the model of care. The model of care should drive the system. And if you're not careful when you buy a system off the shelf and try to fit it in, it doesn't always work. So it's good to hear that evolving dynamic between clinical practice and technology in partnership.
Michael Franco, Chief Medical Officer of St Vincent's Health Australia. Stephen, I'm just really interested, I want to follow you up on your previous answer and just that reality of, you say a clinic's a nightmare now. What's the difference? What's the key difference from typing versus writing it on paper? Is it familiarity? What are the things that we can do to try and get the best of both worlds, do you think?
I've got no idea. It's so non-intuitive. It is so non-intuitive. I think all of us, all of my generation, I was at medical school in the 80s, were very adept at writing down things, and you could go back and look at a diagram you'd drawn 10 years ago and it all made kind of perfect sense. Trying to type out this stuff or use select a diagram from this thing, whereas I draw a tummy or something, it's done in 2 seconds. If somebody's got to click onto the bit where you find a tummy and put stuff, it takes 5 or 10 minutes to do it. So every single thing that took 2 seconds now takes 10 minutes, and nobody quite knows where to find it or how to correct it if they put the wrong dot and things like that. And I appreciate completely. I think this data sharing is really good, but it doesn't help me one bit. I mean, it doesn't help my team. And you'll say, for example, we'll order an ultrasound and see in 2 weeks of the ultrasound. Well, the patient arrives and there's nothing in the system, and they said, but I had it, and they said we'd send it to you. So you end up ringing around, and then they fax it over. So I don't think it solved a single problem. It's just made everything worse, and that's the experience of a lot of people on the ground. Executives think it's great. Politicians love a digital hospital so much. And we had our health minister crying that, the digital health system picked up 500 mistakes in its first day. Well, there probably would have been like 50 in the old system, but there are 500 because no one knows what they're doing. So all of this sort of false propaganda gets put out as well.
One example for me, one of the senior clinicians that has been around St Stephen's for a long time, he struggles with a fine tremor, so he doesn't write that well, and he wants to move towards typing, and he finds it equally frustrating to type and things. So he wants to embrace dictation into the system, but it's a learning curve for him to go into the system, and he's too afraid to move out of his traditional model to move towards that dictation system and things. But again, it goes back to, if there was a piece of equipment that was worthwhile in clinical practice, clinicians embrace it. So we need to make sure that the EMR is a similar type of technology that the clinicians, it's helpful and they need to embrace it.
Thank you. Tim Pegler from Ready Records, so here representing vendor side. First thing, just an observation, we've been doing a bit of testing with integrating the AI tool Heidi Health, and based on my testing as a non-clinician, it lets you look the patient in the eye and listen to them and engage with them, and at the end of your consult you press store and then it spits out the notes in a digestible format, including in plain English for patients. And I believe that if we can get the level of confidence you would all seek in these products, that that connection between patient and doctor will actually start to improve again.
Agree.
My question actually relates to something you said, Peter, and that was around on virtual hospitals. Your teams have an appetite for innovation that is accelerating and running ahead of budget. How do people like myself get around the table with people like you to find a way where we all move forward, get paid, and deliver on future integrated care? And I'll just say one other observation. Michael's work, we're part of that conversation. We have committed to interoperability.
Even though I've not said I'm a digital advocate in that way, I'm a person that wants innovation in practice, similar to the clinicians, and my journey on that pathway is equally as frustrating as the clinicians. And the big bit in the middle, I think, is the cost of delivering that outcome. So I think, for me, there's no simple solution. It's working together to help to identify what those good clinical outcome opportunities are. And if it supports patients in their home environment with a virtual hospital support of clinical support and safety, that's the direction that we need to go. But the other dilemma is, from a private health funder perspective, that's not always encouraged, or it's discouraged because it comes at either no cost or less cost. So it's a journey that we've got to go on. Yeah.
Hi, it's Caitlin from Calvary. Peter, I was wondering if you could offer any commentary on the investment to make St Stephen's digital and whether you think it's paid financial dividends as compared to other hospitals in the group. And if someone externally was looking at this and trying to make a business case stack up, do you think it does?
Good question. Let me think that one through. So from a digital perspective, I think it's great to have the status of a digital hospital. The history with St Stephen's over the last 10 years, roughly, they've been punching way below the weight. They've not been achieving their budget due to the regionalisation, workforce constraints, all those inherent things that you experience from a regional point of view. So that's been a historical challenge. On top of that, circa about $2 million additional each year you've got to make to offset the depreciation of the digital hospital setting. So it comes with a financial challenge. That's just from a each year perspective. That's not gaining, that's just offsetting the depreciation of the digital hospital. I think now we've gone from punching below the weight to really up here. We're using every single bed now. And I think without the digital system, we would not have easily been able to do that because we've already invested in the digital platform for the hospital. And it means that you can look after 54 patients or you can look after 100 patients with the same platform at the same cost. So now this financial year, fortunately enough, we've really achieved budget and we've offset all depreciation costs from a digital hospital point of view as well. Digital hospitals come with an expense. If it wasn't federally funded, would the private organisation fund it? That's a different question to ask. I didn't really answer your question, but hopefully give you some insight. Was that helpful or not? Cool, thank you.
Peter Steve from the Mater. Just a really quick one, and I was always happy to bow to Caitlin first. Question following up on Sue's point, to be perfectly frank, is when's the disruptor coming that's going to make this stuff affordable, right? That's the key to having a really contemporary practice that perhaps solves some of these other challenges that ageing clinicians seem to have as well. But when's the disruptor coming? Because we've got really, the platforms are old, etc. So keen to have your thoughts on that.
I'll just answer one response, if that's all right. So I thought COVID was an example, a fantastic example of a disruptor in healthcare practice. And within the local region and the public sector, they had to come up with a digital solution to support a virtual hospital. And I think it was a fantastic platform because they made it happen and they made it happen safely. That's using the remote monitoring examples to support patients in the community. And then
I think there's not necessarily one disruptive moment. I think it's an ongoing iterative exercise, and we're seeing disruption all the time. And I think to me, this is not a technology problem. It's a policy and a people problem and a culture problem. And what I'm seeing, particularly from the government, is some particularly good incentives and approaches in terms of, the Digital Health Agency are working on concepts for share by default, in terms of ensuring that digital copies of the pathology and medical imaging are uploaded to the My Health record. So over time, you'll see iterative improvements to access to digital health systems and also consumers as well. But I think it's an iterative exercise as well. And to the point around, the investment and return on investment from a funding perspective, I don't necessarily think there is one and you don't see it for quite some time. I think that it's like investing in a piece of infrastructure in terms of whether it's in public transport or roads. You're not going to see the financial economic benefit for quite some time. So I think it's, I guess you won't necessarily see any financial benefit for sort of 10 to 15 years, in my opinion. But I think it is a worthy investment because otherwise there's trouble in terms of managing legacy infrastructure.
Unfortunately, we have to call it there, but our panel members will be around if you do have any further questions. Please join me in thanking our lovely panel.